So our next panel is the value of primary care across the lifespan. It'll be moderated by myself, and I'd like to introduce our distinguished group of panelists, and then I'll join the group. So first we have Colleen Christmas, who is the Rosemary H. Reed Professor of Primary Care at Johns Hopkins School of Medicine, as well as a geriatrician, governor of the Maryland chapter of the ACP, and a previous residency director, and I'm guessing you'll be able to speak on all of those roles today. Next, we have Ben Kornitzer, who is the Chief Medical Officer of Agilon Health, and we'll hear more about that today, and the former CMO of Mount Sinai Health System. And finally, we have Dr. Jim Perrin, who is the Professor of Pediatrics at Harvard Medical School and Mass General Hospital for Children, and the former President of the American Academy of Pediatrics. We've been talking a lot today about the value of primary care and what that, we define those in different ways, but we think about, how do we deliver better healthcare, better outcomes to our patients and think about aspects of equity and spending. I'm hoping we can start our discussion by articulating the value of primary care in the populations that we serve. And Dr. Christmas, I wonder if we can start with you. How do you articulate, define what the value of primary care is in the older adult population? And what does that look like in your practice and in your other work?
This is actually one of my favorite things to talk about, and I could destroy the entire panel by just using up all the time talking about how strongly I feel that a geriatric primary care physician plays an important role in our healthcare system. So we know that primary care in general plays an important role in our healthcare system. Is really the backbone. We protect our patients from harm. We understand them holistically. I think this becomes incredibly important in both young age and in older age, when the impact of environment and society and who's in the home, all of those things play a disproportionate role in the health of an individual. And so geriatricians are very adept at understanding the lives that patients lead and what the facilitators and barriers to care are, and taking the kind of standard templated approach to medical care and recognizing where that's actually going to really harm somebody, where there's a reason why that's not good for this person and what this person needs is a different model of care delivery, a different treatment plan, different people providing that care, so forth. So by sitting in primary care, of course, you're right at that amazing interface between life, patient's world, and healthcare. And so you really have this amazing perspective to be able to understand your patients and what they need, and then target those interventions. So in geriatrics, I think we're really adept at providing care in a lot of different creative models. So thinking about, a younger or a older but very healthy person with lots of resources, they could use the traditional models and be fine, achieve their goals. Somebody who perhaps is more frail or has limited mobility or cognitive deficits, they may benefit from programs like PACE, where the care of the comprehensive care of the elderly for dually eligible people who would otherwise qualify for nursing homes, providing a medicalized daycare type program under a capitated system to keep them healthy and keep them home. Or hospital at home, folks who are sick enough to be in the hospital, but we know the hospital is a constant threat to their health and well-being. It's actually a quite dangerous place to treat them. And so geriatricians have developed these models where they take the hospital to their home. And lo and behold, people like sleeping in their own beds better. They eat more food when it's their food and they get to pick what they want to eat. They don't lose as much mobility. They don't have as much delirium. They have shorter length of stays. It's all around better and saves money. And then there's home-based primary care too. So there are patients for whom coming in for an office visit is actually really pretty dangerous. When I teach my residents, I have a video clip of a patient who allowed me to do this. And it's just her walking in and out of her home. So you see her coming up the sidewalk. She's got a walker. She's stooped and walking slowly. There's a little bump in the sidewalk and she pushes it and goes, and everybody kind of gasps, and she keeps going. And then she's got 4 steps to enter the home. And so she puts her walker to the side. The rails are a little wide apart, so she's got her arms stretched apart, but at least she has rails. Gets up the 4 steps, her purse is on her arm. She reaches in her purse to get her keys. The screen door comes out, so she has to step backwards and step down 1 step backwards while holding onto the door, the screen door, unlocks the door, pushes it open, leans over the rail to grab her walk. The whole thing takes about 11 minutes for her to get in, and it's a terrifying video. And so I often say to the residents, okay, now I want you to think about when you see this lady in the office next week and you think you hear a murmur and you're thinking, okay, I'll just send them for an echo, maybe have them see the cardiologist because they're a little short of breath. Maybe that murmur is related to that or not, and I'll have them get some lab tests. Well, maybe if you're really good, you could get 2 of those things on the same day, but you're probably not getting 3. And so that means at least 4 times you're going to ask your patient to do that, to come out of that house, go back in and risk falling and breaking their hip and dying. So all that is a long story to say that, being able to recognize what our patients really do to survive and bring the needs to them is what we do in geriatrics.
Thank you. Taking a holistic view of the trade-offs of any care you provide as well. Dr. Kornitzer, I wonder if you can tell us a bit more about Agilon Health and how you think about, you as the company and you as an individual and a physician, think about the value of primary care for the specific population that you serve.
Yeah, no, absolutely. And I went into primary care because of doctors like Colleen over here. So what Agilon Health does is we work with primary care physicians around the country to essentially transform their care for all patients over the age of 65 to a full risk model. The question is, what's so special about that population? So patients over the age of 65, by definition, are vulnerable. We also, as part of our thesis, is that primary care is at the center of healthcare and that there is a value to deep and trusting relationships. And finally, that there are structures in place, economic structures for this population, because your older adults are your sickest, costliest patients. So you could really invest in resources with a small subset of patients, but create the economics so that you can transform care and then use those resources for all patients. I was speaking with one of our medical directors last year. He's a primary care doctor in rural Ohio. He is a 3rd-generation primary care doctor living in his grandfather's farmhouse. And he told the story that he was seeing one of his patients in her 80s. And she said that when she was a little girl, she spiked a fever. Her parents weren't sure she was going to make it through the night. And when she finally awoke the next morning, this doctor's grandfather, her pediatrician, was asleep at the bedside. And when he's going to have a conversation with her about, your creatinine is going up, your kidneys are failing. Do you want us to go and place a catheter, get venous access? Do we want to go and begin conversations about palliative care? That conversation will be very, very different because there's a long-standing relationship and you can't replicate that trust. Some of our own internal data shows the more times that our primary care physicians see their sickest patients throughout the year, the better those patients do. They do better on clinical outcomes, but also in terms of the efficiency of care. Now, primary care visits aren't free. There's a cost associated with that, but the fact that seeing a primary care physician actually lowers the total cost of care and the out-of-pocket spend for patients is meaningful. And if you think about the cost of care, it really is a proxy measure for human suffering, right? No patients want to be in the hospital. And so our ability to take patients and do a better job managing their heart failure or their COPD and keeping them out of the hospital is tremendously valuable to that population. Studies out of the VA are showing that every time you see a primary care physician for those high-risk populations, a $700 reduction in the total cost of care for that population. So there's no other specialty that really has that impact of seeing your primary care doctor more and having those dramatically better outcomes. And so really working with this population, supporting our PCPs, being able to invest in resources. So for example, almost all of our primary care physicians now have access to a pharmacist, a dedicated pharmacist that can go make sure that all of their patients, medications are appropriately titrated, appropriately managed. You couldn't do that in a fee-for-service system. And so I think that's really, why that has been our focus.
And I wonder if you can speak a bit more to the specific role that you as a payer play in supporting primary care. What does that look like very mechanistically? Because you're talking about the work that primary care doctors do and your support of that. What are those levers that can come from the payer side?
Yeah, so we're actually not a payer. So what we do is we partner with the PCPs in a long-term relationship. And I think that long-term element of the relationship is really important. So, Right, but the reason why it makes difference is that the investments that you want to make in better outcomes, they can't be measured in a single year. And in fact, you need to have, there were conversations earlier today talking about like the importance of predictability. So you need to be able to understand that if you do the right things, say if you manage patients' hypertension and their hemoglobin A1Cs, that those patients are going to have better outcomes in the future. But the resources to do that take time. And so our ability to invest in that upfront. The other thing that we do that I think is a little bit different is rather than having a slow glide path to value, because everyone agrees value is where we should be headed, I think where people disagree is like, how quick do we need to get there? So all of our practices transition to full risk for their senior lives in under 1 year. And when we're able to do that, we can do things like bring really important data to patients and to their physicians. So for example, if I'm a PCP, I'm really good at seeing the patients who are in front of me at the moment. I'm not sure which patients aren't coming in because they've fallen through the cracks, they've switched insurance plans, they're now homebound, they have dementia, if they've seen a specialist. So we can sort of pull that data together. We can get that data in front of the PCP at the point of care so they can intervene. We can surround them with care resources, with care managers, with social workers, with pharmacists. So the ability to create that sort of holistic environment is unbelievably powerful. But I think what's a little bit different about how we may have approached it than others, we fundamentally believe that the decision making and the orientation of healthcare needs to be redesigned around primary care physicians. And so we give them sort of all of the levers within this model, but it's the PCPs that make all the decisions. And there's conversations, well, PCPs are only part of the healthcare ecosystem. But if you think about it, whether it's a specialist or a hospital, the only element of our healthcare system that's an organizing principle that can work and influence the hospital care, that can work and influence specialty care, that can work and influence that post-acute environment is the primary care physician. So that's why our thesis has been working with and through those PCPs as partners is really not just relevant to the patients that they see in their office, but the ability to actually flip an entire market to a higher value model.
Thank you. Dr. Perrin, we heard earlier from Dr. Lang about this idea that in pediatrics, right, the return on investment is not at the same pace or time scale as we see for older adults. Can you talk a bit about how you think about what the value of primary care is, those wellness visits that we see in pediatrics, chronic conditions, another area that you specialize in? How do you articulate that value and how would you describe it?
So I'm delighted to hear my colleagues also talk about the fact that maybe an 18-month ROI isn't really the be-all and end-all of investment in healthcare, because we really do believe that pretty strongly within pediatrics. There is evidence, by the way, as Ben was saying, even in the pediatric community, that having a higher, more functional primary care system lowers the total cost of care for that population. Most of those are large population studies, but I think there's evidence even at that level. But for children, I think there are two primary issues I would raise. One is, I'm going to get away from children for a moment and say that the United States has a very interesting epidemiology of pathology. And that is to say that we're now seeing over the last 5 or 7 years, a substantial increase in mortality rates of people in the working age population. And those mortality rates don't start at age 45. They actually start at age 20. Now, that's rather damning about what's happening in this country, that we have this, and this is vastly worse than any other industrialized country. So I was on the call with a friend of mine in London this morning, and in all of the European countries, there continues to be a decline in mortality, not in the United States. Actually, we're doing pretty well on people over 65 or 70. That's good, but not younger than that. It's a remarkable thing. And we do know that much of the things that people are dying from, suicide, drugs, severe mental health, increasing rates of cardiovascular and diseases and metabolic disorders in people in their 20s and 30s, many of them can be prevented if we did a better job for kids. So that's part of how we think about the return here for sure. But even so, we've talked a lot today about the value-based investment. For children, the value can be measured in a variety of ways. It's not usually going to be to say that we're really saving the cost of care in a short term. Yes, we can do some minor things in the NICU and cutting down on emergency department visits for young people with asthma. But in general, the cost savings in the short term are things like immunizations. We all know that saves a lot of money. And frankly, the family. That the results of having high quality care for kids is often reflected in the family's ability to do the rest of the things they want to do, to participate in the workforce effectively, not to be distracted by the fact that my kid's, taking drugs and may not come home from school safe today. So if you're not distracted, you're a better worker. There are other savings as you go along the life course. So way before that age 20 or 40, but there are savings in the less use of special education in school age years. There are savings in the areas of adolescent health and well-being, STDs, substance use, significant mental health problems, incarceration as adolescents. All of those you can decrease with much better high quality primary care for children.
I'm curious, tagging onto that, is there evidence of or quantification of the opportunity costs for parents or days off of work due to childhood illness?
Not very good. We actually tried to get funding to do that kind of research 20 years ago and couldn't get it. But I think it's a tremendously important question. We actually did some work 5 or 10 years ago, 10 or 15 years ago, with best practice companies in 4 U.S. cities. I remember American Airlines was one of the outstanding ones. I actually flew American today. This is not meant to be a plug. But they actually had employee benefits that were designed around making sure that the kids were getting good services so that, pilots wouldn't call out and say, I can't come in today. It was incredibly important for them to do that right. Did they do good actuarial evidence to support that? Unfortunately, they didn't. I'd love to see it. So I keep encouraging young investigators to do this work.
And so I realize that I am probably the best representative on this panel of the 18 to 19 to 64 population. I'm a general internist. I take care of patients 18 and up. I don't do kids, and I wish I could. And so in that context, when I think about the value of primary care, one of the first things that comes to mind that keeps me up at night is the challenge we have in convincing patients of the value of primary care, especially in that younger set, right? The 18 to 34-year-olds, and we have evidence, we've seen declines in primary care visit rates across populations, including in older adults, but the declines seem to persist and be most prominent actually in that younger set. And it makes some sense when you think about the other options out there, right? We have convenient, minute clinics and other kinds of settings where you can get that sort of specific need met, but it's not the same as primary care. And so I was reflecting on this earlier this morning, but I talked to the patients who I already have a sampled, a biased sample, but the patients who do come in to see me, we have a conversation about, what is this relationship going to look like after that first visit? And so what I say is, now you have your person, I'm your person. You don't have to come see me every year. I'm imagining like a healthy 20-year-old, right? See me every couple of years. Otherwise, just so we can check in. And now, if anything comes up, you have the person you can turn to. And I think that kind of message is, I wish I could reach people who aren't coming in to see, who don't have access to primary care. And I know that how hard even my wait times are. But that's a message that I think we need to do a better job collectively of spreading to the public, and especially in that age group, I think, where you don't really see that benefit as much. I wanted to turn next to the idea of the expansion of the idea of how we deliver healthcare. And so, traditionally, of course, really traditionally, there was, I guess, the doctor on the horse going to people's homes. That was before my time. But then in more recent tradition, everything was based around office-based visits. And we know that primary care in particular is really moving outside of those paradigms. And when I say that, I'm talking not only about telemedicine, which of course predated COVID, but was really accelerated by COVID, home-based care that Dr. Christmas was alluding to, remote patient monitoring. There's so many different ways in which we're expanding the reach of our care beyond that traditional visit. And I wondered if we could I'll open it to the group, whoever wants to start, but I think you could all say something about how those alternative sort of modalities of care or ways of delivering care has impacted your populations and what you see as the future there.
I'm happy to start. So with the pandemic, the peak of the pandemic, of course, all practices suddenly had this crash course in telemedicine. What seemed impossible before, too challenging, we all figured it out really quickly. And that was certainly stressful times, but we learned a lot from that. I learned about telehealth in a way that I really didn't anticipate. So some of the benefits we experienced during that time and continue to benefit from now, one is that of a virtual home visit. So I've often said, you need to the trainees, I'll say you need to do some home visits so you start to understand people's environments and their real lives and how you work that into your treatment plans and so forth. But here you have the opportunity with telehealth to be in their home without being in their home, without having to drive around and find a parking spot and so forth. And that has served several functions. One is that you get a feel for what the home is like. They'll say, gosh, I'm having a hard time getting in and out of the tub. And I'll say, can you show me what that looks like? Show me how you're doing that. And they'll take the camera in and show me where the tub is and where the toilet is in relation to that. And the grab bar is too low or the step is too high or whatever the issues are. So there's a, show me component to it. Show me how to use your inhaler. They talk about their inhalers in the office, but if they don't have it with them, so you have this opportunity to see, to really understand their problem on a different level. You also have an opportunity to understand their home, who's in the home and how does it roll. So, there's sometimes where you're trying to do this visit with people and there's, strangers walking past in the background and somebody's screaming and it's just so chaotic that the idea of saying, I think for your insomnia, we should do a little meditation seems laughable, right? So you have a much more practical sense of like what's happening in the home, who's there, what are the resources we can use to help this person. And then I think the third part about the virtual home visit is that it really does connect you very nicely. Like people talk about their grandchildren, but there they are and they want to say hello to you. Or I have an artist who still paints and tells me about her work, but went during COVID. And she's a quite healthy person. So there's no reason for me to make a home visit. But during the height of the pandemic, we did a virtual visit and she showed me her artwork, which was amazing and lovely and just a wonderful way to connect. So I think the virtual home visit offers a lot of opportunity for our patients. I think the second part about, a second big thing I learned about during this trial by fire with telehealth was that these visits have a tremendous potential to coordinate care. So there were a couple of times where I was actually able to join a visit that was happening with a specialist. I had a patient who was isolating on the Eastern Shore far away, developed visual changes, had abnormal eye findings on my exam, and I got a neurologist to do a visit with me. And so both his primary care doctor and the specialist, not only could we coordinate care, we could do it in real time with the patient involved. That's pretty powerful. That's pretty amazing. So I think there's also, certainly lots of technologies we're bringing to the bedside, to the home. We can do home hand-carried echoes and monitoring devices and so forth. But I think the opportunity to do some of this coordinated telehealth care and to do virtual home visits are tremendously beneficial.
That's incredible. Dr. Christmas, can I ask you I'm so curious about just what went on behind the scenes when you were trying to coordinate this visit with the specialist? Because I'm thinking about all of these barriers that we encounter in traditional primary care of like, well, my clinic session is on this day and his is on this day or hers. So just give us a little more detail. I would think we could all learn from what went on to make that happen.
Yeah, no, I think about it a lot too, to be honest, because I think it's hard to replicate now that I'm not back there. They're not full-time telehealth and I'm not full-time telehealth anymore. And so the schedule suddenly got much more difficult to figure out how you're going to coordinate that piece. At the time, we were both doing full-time telehealth. They were the only one who billed, by the way. We negotiated that out. But so that's another issue, is figuring out the payment structures. Yeah.
Yeah, because it would be great to replicate that, but there's so many, yes.
Yeah. Imagining a way to schedule it so that you would have opportunity to join these things. Or, certainly now that we've kind of broached that barrier, patients certainly can be in the office with their cardiologist and pull me up on their cell phone if I'm available. Again, it's that scheduling piece tricky, or vice versa. While I'm seeing the patient, if there's something going on, I'll often text their cardiologist and say, "Hey, Sammy, are you available?" And if so, I've done the reverse, had them join in the office that way.
The other thing I'm hearing as you speak is you have those relationships with the specialists, which is wonderful. And I think many PCPs do, but some don't as well. And that's the other, and differential access to specialists is another issue.
For sure.
Other thoughts?
Yeah, I think this has all been, as Colleen said, a crash course and tell for all of us. One of the stories that I recently heard from a friend of mine who's a CFO of a health system, Ishani, that you're familiar with. He shared that he was in an emergency room on vacation in a New England state, waiting to be seen by an emergency room physician. And it went 1 hour, 2 hours, 3 hours, and the emergency room physician was still backed up and couldn't see him. So he took out his iPhone, signed up for a primary care organization that does telehealth. 15 minutes later, got a ping, had a visit in the emergency room with a primary care doctor who walked him through what to do, wrote a prescription. He went to CVS, picked it up, and didn't even see the emergency room physician in the first place. And it just sort of shows the value of primary care and being able to connect with patients where they are is really disruptive. And the whole healthcare ecosystem that we've created, which is unbelievably inefficient, a lot of that care can be disintermediated. In my role at Agilon, we, more than just the convenience for the patients, which is important, really, how do you focus on those highest risk patients? And so, as Colleen said, there is that subpopulation of patients who are homebound for a whole variety of reasons, and our ability to come meet them where they are is disruptive. And I actually think it's beyond just, the most sort of glitzy new technology. We find that just a phone call can be unbelievably impactful. And in fact, things where there may not be a billing code to do, but we find really make a difference. So for example, you could have a patient with dementia who's discharged from the hospital, spending the time to make a phone call to her family members, talk about the care, talk about the medications, talk about what symptoms to watch out for, right? This is technology that's been around for 100 years, a telephone since Alexander Graham Bell, but you still can have, tremendous impact. And then at a larger level, we see the ability to do things like remote patient monitoring for patients with heart failure. So many of our practices have deployed technology where on a daily basis, patients take their weights, they take their blood pressures, they report their symptoms. And what we find is what you can do with those high-risk populations is dramatically reduce their avoidable admissions for things like CHF or COPD. And so I think our ability to leverage that technology by knowing who's that high-risk population and then being able to give them sort of a level of care and attention and do it in a longitudinal way. And I think that's sort of a fundamental difference in primary care. It's not episodic. We're concerned for the care for the whole population. And again, in our model, our physicians, right, they know who that attributed population is. And so they're not just worried about the patient who's in front of them at the moment, but all of those patients who aren't coming in. And so using technology to be able to monitor them, how they're doing, and even things like we get real-time feeds when one of our patients goes to the emergency room. So you could be a patient up in Buffalo, but you could be wintering down, in Daytona, Florida. All of a sudden, if you go to the emergency room, your primary care doctor knows that. And how delightful it is that the next morning you get a phone call saying, Mrs. Smith, I'd like to talk to you. How are you feeling? What are your symptoms? And so I think our ability to connect those dots can move the needle on not just the care in the moment, but in fact, how patients experience care over longer periods of time.
I think it's two things in response to you, Ben. One is it would be great to make sure that we can do that across state lines, which is a real problem that many of us are facing right now. And yet it would be a tremendous advantage that your patient in Miami or wherever in Buffalo can get the care that she needs. We are certainly finding that with many of our adolescents going off to college, that they need to talk with us about their depression or whatever else. They need their meds at times. And now that they're across state lines, it's creating some really very complicated barriers. The other part of it is, why worry about billables? Wouldn't it be better if you just had a healthcare payment system that allowed you to take care of these people based somewhat on their need and risks? And which is what I think we're actually aiming to. I think in pediatrics, we've seen a lot of very similar issues evolve. We've had a long history of actually using various sundry telehealth methods, but most importantly, and again, Ben said it in a different way, an awful lot of what we do in offices doesn't need to be done in offices. My friends in obstetrics remind me that the average healthy mom gets 15 visits in prenatal care, 14 of which are irrelevant. That's not okay. Almost everything that's done in those visits could be done in a home or community setting. The same thing is true in pediatrics increasingly, both in subspecialty care and in general pediatric care. But it needs to have still that relationship to make the sort of whole cloth out of the set of situations here. So I think those are the changes I see coming. And I don't think we're going to have so many offices in the future.
Dr. Perrin, I'm curious about those virtual visits you're doing with the young kids. What does that look like? Are they like, can you keep them in one place?
And first of all, we don't do many direct visits with under 5-year-old kids running around the house. We may be interested, as Colleen is, in what the house looks like and how it's set up. And, the reality is, for all of us, our patients come from very, very diverse backgrounds, communities, homes, and so forth. So talking about teenagers, especially dealing with some of the mental health issues that have been relevant, telehealth has been in many ways a tremendous boon to our ability to do that. And telephone has often been much more valuable than any kind of visual thing in our work with adolescents. On the other hand, we also have kids who live in housing that is so tight, there's no opportunity for privacy at all. Some of our kids don't care. I find that interesting, but many of them do. And that's created some other issues about how do we make it work, right?
Yeah, I think the phone versus video question is so interesting. We did some recent research looking in the Medicare older adult population, both in traditional Medicare and Medicare Advantage. And we find that patients are often choose or actually have a phone visit even when both are offered to them. And I think some of the policy debate has really focused on sort of the assumption that video is always better. And I think those of us who've practiced, right, we see that it's not quite that clear. First of all, it's really hard to see a rash on video, even in the best light. Video has some strengths for sure, like, body language and eye contact, especially if you're meeting somebody for the first time. But phone can often be just as good, or almost as good. And, when I practiced at a clinic, but well before COVID times. And it was a global budget through an employee model. And we used to regularly schedule phone visits, especially for mental health care. And we found that was incredible. Patients liked it. They didn't have to worry about how do I log on. And so I think we want to expand that conversation about, what is an acceptable form, and really to the idea that whatever a patient needs in that moment, what's good for the patient and the clinician is what we should do. And moving away from fee-for-service payment to give us that flexibility is really a big part of it. I'd like to move us to the idea of team-based care. As we know, primary care is a team sport, and specifically around the idea of how do we think about teams when addressing social determinants of health. I think one of our participants earlier today was asking a really good question about, this idea that, in primary care, we can't do everything. And increasingly there is interest and focus on the ways in which social determinants in some ways play a much bigger role in the health of our patients than even what we can achieve. But really, what is the role and the responsibility of primary care in helping with those issues? And so I would love to hear about how in each of your populations you think about addressing social determinants, and specifically how you think about teams and partnering with other members of the care team or even externally to address those issues. You can go down the line, or whoever wants to start.
I mean, let's start. Actually, lots of things to say here. So I have the advantage of early imprinting in this area. When I was a very young physician, just putting my shingle up after my fellowship, I was in a couple of rural communities between Rochester and Buffalo, New York, and I was fortunate to have some federal monies for our clinic that allowed us to have a really quite serious community health worker staff. And there was this, I thought, very old lead community health workers. I was like 30 and she was 45 those days. But she taught me so much about the community, issues I had no idea about, that it would never have crossed my mind that were influencing healthcare and the care of families. I also started that practice with a nurse practitioner. And there too, I thought, wouldn't it just be nice another person to help out? It was much more than that, frankly. It was the fact that First of all, I'm an old white male. I was a young white male in those days. And there were certain things that moms and dads would not talk to me about, but they would talk with a nurse practitioner about, and vice versa. And I think it was a tremendously valuable learning experience for me. My life has been downhill ever since. But nonetheless, I think there's really a great deal of evidence that we have to build teams, that we're asked to do far too much in primary care to be done by just the physician herself. And I think the teams are going to vary. But from my viewpoint, those teams include nurses who are much better than doctors are about chronic care management, frankly, that need to include mental and behavioral health people in the practice. The notion of having to send someone 3 miles away 3 weeks from now for care is absurd. And they have to include community health workers as somewhat equivalent, depending on the community that you're in, but they're critical in dealing, among other things, with mental and behavioral health issues. They're critical in linking people to communities. You raise the question of social determinants. It's broader than that, really. It's a series of other community resources that are critical from our viewpoint: schools, preschool, but also housing support, income support for families, tremendously important for young families, et cetera. That's what you can get from a team. And we're only going to get there if we start to move away from fee-for-service arrangements. It's extraordinarily difficult to build a team based on trying to widget our way through everything that the team members do. So we do have to do that. And I would say in Massachusetts, our Medicaid program has moved with its most recent waiver to a primary care partial capitation arrangement. It gives you incentives to have mental and behavioral health people in your practice. You get more money if you do it. And it gives you more incentives if you have community health workers in the practice. Is it going to work? I don't know. Someone asked a question about ACOs earlier. We had ACOs in Massachusetts for 5 years. They didn't work through our Medicaid program. But we can discuss that. It really did not change payment arrangements very much, actually. But this may work. It really may be a way of getting us further along that line. We're optimistic.
If I could step back for a moment too, as we think about the role of teams in primary care, there is a burning platform right now in primary care. So I think in the most recent measured year, 30,000 adult primary care physicians left the practice of medicine. That's unprecedented. There's no pipeline to replace them. We have a aging population with more chronic needs. We have communities throughout the country, particularly communities that are in medically underserved areas, either rural or urban geographies, that are at risk of becoming primary care deserts. One of the statistics that's always been, so compelling to me is the fact that communities that have more access to primary care, people live longer. I mean, that is just an unbelievable statistic. And so the ability to go and deliver the care we need can't only rely on physicians with a one-to-one relationship with their patient. In fact, we see, quite honestly, as Jim said, our pharmacists do a better job titrating medications for heart failure patients than PCPs do, right? Because PCPs just have in fact, they do better than heart failure clinics at those measures. We also, and again, this is a personal belief, but also it's been borne out in the literature, like one of the most important prognostic factors for how patients do is having someone who cares about them. And it doesn't even matter so much what the letters after that person's name are. And so if that's a care manager, if that's a pharmacist, if that's a social worker, but it's that whole notion like the value of a trusting relationship. Now, the primary care physician has an invaluable role as sort of the quarterback of that team, the conductor. But the fact that we can go and have patients feel comfortable seeing a nurse practitioner or a social worker or a care manager, or sending people into the home, some of whom may just be community peers. It's creating that dynamic ecosystem of people who actually care about the patient, right? Like day one of medical school, they teach you the secret for caring for patients is to care about the patient. If we can create that group of individuals that take accountability in a longitudinal way for patients, that's what's really transformative.
I just want to echo a couple of things that my colleagues already said. So, yes, 110% agree that I can't address everything in the office. It's impossible. There are not enough hours in the day. So need people to help with the care, but also agree that those people are often better. I don't have the skill set that they have. they're often better at certain things than I am. And so collaborating with them to do that. We have a pharmacist who does like diabetes management. That's fabulous. And I think I do a good job with diabetes. But, she can spend much more time talking in detail about the diet and doing a nutrition. What takes her a 30-minute visit for that one problem. I've got 30 minutes for 7 or 8 problems. And so I don't do as good a job with that. So I think they have skills that we don't have and we can utilize, and we can't possibly manage everything on our own. They find out things that we don't find out because of the skill set or because of different, hierarchies or whatever the issues are. And then the final thing is, I think that we like to practice in teams. I think primary care can feel very, very lonely sometimes. I think a lot of our trainees will talk about how in hospital medicine, they're working as a team. There's people around to talk to and bounce ideas off. And in the office, you feel like you're on your own very often if you don't have these services at least embedded in your practice. Ideal would be to have them all embedded in your practice. At least we have access to many of them. But I think this idea of like, I'm part of a team, a community that's really all sharing the same value set about trying to help get older people to live healthier, more fulfilling lives. That feels wonderful. So I don't know how to the degree to which that will reduce the burnout issue that we're having, but I think it's got to help.
I think that sense of meaning that you get from the patient relationship, but also from all the people who are mission oriented around you makes such a big difference.
The time went by really fast. I'm realizing we're at the end already. That was incredible. Thank you all. I want to just end, if we can have like 2 more minutes, to have each of you share. So premise is that we need to bring in our next generation into primary care. And there's this tension between and we talked about this last night, Dr. Christmas, between making sure that people come in eyes wide open about the challenges and fixing those challenges, but also showing the joys of primary care. And I wonder if each of you could just say one sentence about how you talk to your trainees or the future generation about why you do what you do and why they should do the same.
But I tell them that I love my job and I can't imagine doing anything else, quite honestly. And I usually will share with them a story about a patient that I have. I often think like if my students could all just meet a couple of my patients and be on the phone when they call and say, Dr. Christmas, I saw a doctor specialist and he had these ideas for me. But I want to hear what you have to say because you know everything about me, and that's someone that I've known for years. And I do know a lot about them, probably not everything, but I do know a lot about them. And I know that they trust me to make a decision. That feels incredibly rewarding. It is such a tremendous joy to be able to walk with people through the ups and downs over a long haul and have them know that you're going to be there regardless of what's going on. So I help people live better lives, and that's pretty audacious. So yeah, I hate the paperwork. Everybody hates the paperwork. That's got to be fixed. But I believe those are problems that are fixable. I believe moving towards value and focusing on that instead of widgets, these are fixable problems. I think that AI is going to replace certain fields of medicine and augment others. I don't think it will ever replace primary care because primary care is a human to human endeavor. It's about the magic, the secret sauce is having that connection, that trusting relationship, and we will always have that.
Yeah, well, I know exactly what I will tell residents and the future medical students. Speak to Colleen because she said it perfectly. So let me actually step back. And, one of the things that I will say to people is I think the future has never been brighter for primary care. Our country is at an inflection point in terms of how we are resourcing care. Technology is developing in such a way that primary care physicians can now have insights, not just in that patient in front of them in the moment, but in fact, across that whole panel. And again, this is my belief, but I think there's increasing proof points that healthcare is being reorganized around primary care doctor in terms of the economics, in terms of the outcomes. And so all the things that sort of dominated healthcare in the past, large facilities, right, subspecialty care, all of that is going to be reorganized around what's the best for the patients. And primary care doctors are uniquely positioned to have an impact there. And so I really think folks should be unbelievably optimistic about what the future holds.
So I agree with both of you very much. I would say two quick things. One is I have to pick up on Beth Lang's comments from before. In pediatrics, half of our kids are covered by Medicaid. We've been taking deeply discounted payments for half a century. What other industry would take such deep discounts? We don't have any other industries in America that actually have taken the deep discounts and haven't gone out of business. So one is we're working to change that and make your lives better. And number two is there is something unbelievably special about seeing a new baby who's a few pounds large, and to watch that young person grow up to be a 6-foot tall basketball player. It is an unbelievable privilege and an incredible honor, and what a great pleasure for me.
Thank you all. It's a really wonderful discussion.